Good morning and welcome to the JASN podcast, where we highlight an interesting recent paper from the journal. I'm Dr. Alessia Fornoni, professor of medicine at the University of Miami and a deputy editor of the journal. I'm joined today by Dr. Sandeep Mallipattu, chief of the Division of Nephrology and Hypertension at Stony Brook in New York, and by Dr. Bhaskar Das, professor, division chief and director for drug and biotherapeutic discovery at State University of New York at Buffalo. We will be discussing their paper entitled A Small Molecule Agonist of Krüppel-Like Factor 15 in Proteinuric Kidney Disease, which appeared recently in JASN. Dr. Mallipattu and Dr. Das, please introduce yourself and tell us a little about your background.
Sure. First, thank you, Dr. Fornoni and Jason, for providing this opportunity to highlight our work. As mentioned, my name is Sandeep Mallipattu, Chief of Nephrology and Professor of Medicine here at Stony Brook University. Our work over the past decade and a little bit beyond that has really focused on these family of zinc finger transcription factors called Krüppel-Like factors in kidney health and disease, in hope of identifying potential druggable pathways in their mechanisms of action. Dr. Das.
Good morning, everybody, and thank you, Dr. Fornoni, for giving the opportunity to discuss our science. And I am Bhaskar Das. I recently joined in the University of Buffalo as the director as well as division chief of the drug therapeutics and biotherapeutics discovery. My background is a medicinal chemistry and chemical biologist. So I am working with Dr. Mallipattu since last 12 years. So we are developing small molecules for the kidney diseases and targeting different signaling pathways. So we develop the compounds starting from the new target identification, validation to the clinical process. Thank you.
Thank you. Thanks again for accepting to participate to the podcast. Let me start with some questions. Dr. Mallipattu, what are the major challenges in the use of glucocorticoids for the treatment of primary glomerular disorder in both adult and pediatric patients?
Thank you. And this is really the question, right? As clinicians, we wrestle with this all the time. While there are really a subset of patients with primary glomerular diseases that really benefit from glucocorticoids, it still really remains unclear which patients will benefit at the start of therapy. Furthermore, as you know, KDIGO guidelines, the grade of evidence for the use of high-dose glucocorticoids for a period of several weeks in adults as well as pediatric patients to determine response to therapy is really at grade 1C to 1D level of evidence, which is on the lower end. Additionally, patients are on glucocorticoids high doses for prolonged periods of time, especially if they have recurrent or relapsing disease. So one may ask, well, what are the challenges with it? As clinicians, we deal with this all the time, where chronic use of these agents is really riddled with systemic toxicities that might range from detrimental impact beyond the disease itself. And some of these include weight gain, bone disease, hypertension, infections, not to mention neuropsych issues, as well as gastric ulcers or cardiovascular disease. So therefore, really, it's twofold. One is it's unclear which patients will benefit from the start of therapy. And number two, the systemic complications or morbidities associated with these agents are the challenges in the field.
Thank you. I cannot agree more with your statement as a practice in nephrology. So let me ask you then, how does targeting the KLF15 may allow for similar efficacy and less side effects?
So actually, our story really started, more than 10 years ago, actually, in early 2013. And so we had been studying potential mechanisms of how glucocorticoids might mediate their effects in podocytes. And so it's been shown previously by other laboratories that the glucocorticoid receptor is present in the podocytes. And so there are direct effects of glucocorticoids in the podocytes, so binding to the glucocorticoid receptor in the cytoplasm and translocating to the nucleus to mediate its effect. Along this way, we were looking to see, well, what are potential downstream targets of glucocorticoid receptor that we could potentially target that may not have the similar systemic effects as the use of these agents. So one of the molecules, early inducible genes, is this gene called KLF15. And it's been shown by other laboratories and other systems as well that KLF15, or Krüppel-Like factor 15, is an early inducible glucocorticoid responsive gene. And it's involved in not just a positive feedback circuit loop with glucocorticoid signaling, but more of a feed forward along with other glucocorticoid responsive genes. So using this information, in fact, in JASN in 2016, we demonstrated that KL15 is not only a glucocorticoid responsive gene in podocytes, but also the loss of KL15 attenuated the renoprotective effects of the steroids in murine models of proteinuric disease, while maintaining this, without changes in the immunomodulatory effects of glucocorticoids. Subsequently, in 2018, a couple of years later, we also showed that the genetic induction of human KL15 in podocytes really attenuated the progression of podocyte loss and eventual glomerular sclerosis in these proteinuric mouse models. So and there were no systemic effects along with with the induction of KL15. So using this information, our hypothesis really at the start of the study was to show that, well, it seems that glucocorticoids certainly have beneficial effects, potentially that may be direct to the podocytes, but targeting a molecule that's downstream of the glucocorticoid receptor pathway might maintain similar efficacy without the systemic effects.
Amazing. So now, building on this excellent piece of experimental nephrology, you have now developed a novel agonist for KL15. What is the specific mechanism of action of this molecule?
Yeah, so it has taken us some time to really understand how our agonist really works. So let me just kind of step back and say first that KL15 is in a family of zinc finger transcription factors called Krüppel-Like factors, and initially identified in the early 50s in the fruit fly, the Drosophila, where they showed mutations in Krüppel-Like factor results in embryonic lethality, as well as body segmentation defects in the fruit fly. So the mammalian orthologs for KLF, there are several members in the family, but KL15 specifically was actually identified in the kidney, and the other name for it is kidney-enriched KLF15. So it has been shown to be an early inducible responsive gene to glucocorticoids, as I mentioned. But what was interesting in our investigation to understand the mechanism is that it's been shown that NF-kappa B signaling is activated in podocyte injury in primary glomerular disease, as well as in some of the other cell types in the kidney. So what we showed here is that the agonist, through initially a series of unbiased sequencing studies, RNA sequencing studies, subsequently we showed that the agonist actually binds directly to the regulatory complex of NF-kappa B signaling. So the kinase called IKK beta, and it inhibits its kinase activity. So in activation of NF-kappa B signaling, typically once the signaling gets activated, it releases the dimers, NF-kappa B dimers, from the cytoplasm to the nucleus, which results in transcriptional suppression of KL15. What we observed here is that our agonist actually directly binds to the kinase that prevents that translocation of the dimers, therefore restoring KL15 expression. So how did we do this to show is that we actually mutated the binding pocket in the kinase to show the kinase activity inhibition was mitigated in the setting of the mutation with the agonist. And subsequently also showed that, interestingly, the knockout of KL15 also inhibited the protective effects. So what we really got out of this study is not just the potential direct mechanism of our agonist, but also to show it appears similar to glucocorticoid signaling. It appears that NF-kappa B signaling, specifically the canonical NF-kappa B signaling in podocytes, seems to be mediated through KL15 as well. So demonstrating that there's a close crosstalk potentially between GR, or glucocorticoid receptor signaling, and NF-kappa B signaling in podocyte injury.
Thank you. And very nicely, you have gone from target identification to drug discovery. So can you please briefly describe the process that is required to go from target identification to actually have an agonist in your hands?
Thank you for the question. This is really, I think, where, team-based science has come through, with our colleague here on the call, Dr. Bhaskar Das, with his expertise in medicinal chemistry, we really leveraged the resources that his group has investigated over many years. So the first part of the target identification drug discovery really started with us developing an assay for KL15. So we utilized human podocytes and culture, designed a reporter assay for KL15, where if we were to treat with specific compounds or screen with screen of compounds, we can actually see which compounds will induce KL15 reporter activity, meaning the activation of the promoter. So we initially underwent this, where we designed the assay. We subsequently repurposed the National Institute of Health NCI library of compounds that are available. From that, we identified the target to hit compounds that induce the reporter activity a minimum of threefold, and that was reproducible without cytotoxicity. And we demonstrated that we identified compounds that had an EC50 of less than 100 nanomolar. So from this, initial target to hit, we then collaborate with Dr. Das, who can explain further how to identify which compounds would be ideal, could be druggable, that meeting the Lipinski rule of 5. So Dr. Das, perhaps you can go from here to show how you took the compounds and then transition to a structure-activity relationship to generate the structural analogs.
Yes. So from the initial screening, from target to hit, then we did the SR structure activity relationship. Our lead compound had the MID group. This MID group are very prone to cleavage in situ, in vivo systems. So this MID group we converted to oxadiazole, which is basically basically peptidomimetics, the mimic of the MID group, the oxidized group. And when we design the compound, we always look for the Lipinski rule of 5, how to reduce the toxicity, how to increase the specificity, how to increase the bioavailability, how to increase the cell surface membrane permeability, which all these parameters, keeping in the mind, we design the compound on the pharmacophore group, MID group, we converted to oxidizole. Then we added a chloro group, which will be more hydrophobic to cross the cell membrane. These so many chemical properties as well as medicinal properties we consider, and then we design the compound. Around 20 compounds we design, and out of that I gave to Dr. Mallipattu and he tested the compound. Out of that we found our BT503 is the lead compound.
Thank you. And do you expect that the KLF15 agonist would work across different proteinuric kidney disease, Dr. Mallipattu? And is there any reason to believe that they may even work in steroid-resistant form of proteinuria?
This is really an important question. In the proteinuric models that we tested, for example, we even tested in a model of HIV-associated nephropathy, a classic collapsing FSGS model where we showed a protective effect. And interestingly, in that, we were able to show that there's NF-kappa B signaling activated, and therefore, potentially, this is why the agonist had a protective effects in this setting. So we hypothesized, at least at this stage, based on our series of experiments thus far, is that it'll certainly depend on diseases that have an activation of NF-kappa B signaling in these primary glomerular diseases to see if it would have a therapeutic effect. In the paper that we published in 2018 in JASN, we did demonstrate in a cohort of kidney biopsies from patients that responded to glucocorticoids versus that did not respond to glucocorticoids. So therefore, at the time of biopsy, they had been started on steroids. And what we observed is the expression, and specifically even the podocyte-specific expression of KL15, correlated with their responsiveness to glucocorticoids. Now, at that time, we were unsure on why is KL15 low in a subset of patients that did not respond to KL15. So right now, we're undertaking studies to identify perhaps, and this is still a hypothesis, And we're excited to do these studies that potentially there's a dysregulation of NF-kappa B signaling in the patients that are steroid resistant. And perhaps our agonist could have an effect in this setting. But the studies have not been completed. And so we're looking forward to completing those and hopefully sharing that with the community.
Looking forward to these additional studies that will allow for better patient stratification and for precision medicine. That's what we're aiming for in nephrology these days. So what do you think are the next steps needed to make this novel, new, exciting compound available to our patients?
Thank you for the question. I mean, I think that's what really ultimate to, translation from, bench to bedside. And this is where, Dr. Das's input would be valuable as well. We're actually in the process of reporting all the pharmacokinetics, the pharmacodynamic, as well as toxicity studies, and partnering with industry to see really if we can use the compound in a setting of in good laboratory practices and good manufacturing practices protocol, so it could be ready to file an IND application and presumably go towards phase 1 clinical studies. But Dr. Das, your input as well in this.
Yes, so this is our lead compound, and when you design this compound, not only how the compound will bind to receptor, but also when we think how once it binds to the receptor, what happen other reactions, and how how it will reduce the toxicity profile as well as off-target effects. The off-target effects is the most viable things in the drug discovery, and that off-target effect is really failed in the clinical trial. So we, rather than keeping one step, how to bind the receptor, we think 2-3 steps ahead. What it binds, what our organic reaction will do in situ. How to protect that, how to protect off-target effect. So taking these things in consideration, so our BT543 is the lead compound. We are also in the process to develop little bit more safe compound with the backbone of our oxidizable compound.
Thanks a lot, Dr. Mallipattu and Dr. Das. I think your elegant work really prove how interdisciplinary and team science can provide hope for new treatment strategy for our patients affected by proteinuric disease. So thanks again. I really appreciate your time today.
Well, thank you, Dr. Fornoni and Jason, for the opportunity to present our work, and we look forward to sharing more studies in the future.
Thank you, Dr. Fornoni, and also Natal. It's a great pleasure to talk to you, and thanks for donating your time to take our science to a little bit further. Thank you very much. And thank you, Dr. Mallipattu, for giving me a chance to work with you. It's my great pleasure.
Have a great day, everybody.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.